All right. And I also have the pleasure of introducing our next set of presenters. And then I just realized that I did not do a good job introducing myself. So, first and foremost, let me rewind a little bit. My name is Michelle Shepard. I am a general pediatrician. I practice out at the UVM Medical Center Pediatric Primary Care Williston site for about three-quarters of my life. And then I work with the PQC Vermont Icon VCHIP team. And I've been with Icon now since 2017, and now lead faculty of this group. So I'm now going to introduce my co-presenters. So today, and many of you have probably met our presenters and have familiarity with them and their roles today. So Katie Leffel is presenting with us. She has worked in a variety of nursing settings before coming and settling into the community and public health nursing space. She's spent over 13 years with home health in the maternal child health evidence-based home visiting, medical and lactation nursing models. She's currently working for the Family and Child Health Division at VDH, where she focuses on perinatal health, system building for Vermont's public health perinatal work, and as a liaison to the PQC Vermont, specifically perinatal substance use content expert. She works on the maternal mortality data that you saw earlier and also supports nurse embedded in all of the 12 local health offices. And our other presenter today is Kayla Penko, who many of you may know is a nurse and has been in the perinatal field for the past 12 years. She's worked at the antepartum, postpartum newborn nursery unit at UVM Medical Center as staff nursing and nurse educator. And in January of 2024, she moved over to join us as the AIM Healthcare nurse educator, working for the Vermont Alliance of Innovation on Maternal Health, or AIM. She's also working with our PQC team to implement obstetric patient safety bundles in all of our birthing hospitals in Vermont. She's also remaining per diem at UVMMC and teaches clinical nursing to Norwich nursing students. She's passionate about the safety and experience of birthing people and their newborns in Vermont. And she lives up here north with me in Sheldon, Vermont with her husband and three kiddos. So I guess we're ready to roll. Next slide, please. Oh, yes, and we have no disclosures, nothing relevant in the financial or conflicts of interest to resolve. Next slide. So we do have some learning objectives today. So we're going to spend some time understanding Vermont's approach to the family care plan and the changes that have happened over time. We're also going to briefly review the federal legislation, Child Abuse Prevention and Treatment Act and Family Care Plan changes throughout this legislation. And then Kayla's going to take over to review updated CAPTA and Family Care Plan tools and review next steps for our state partners. Next slide. And I'm going to turn it over to Katie.
Hey everybody. So this is a slide you just saw, and I just always like to slap this up because I think it's really, really important to do this, and especially that third point of honoring the people whose lives have taught us so much about substance use and pregnancy in particular and postpartum period. Next slide, please. Oh, I just did something funny to my screen. Okay. So this is some of the data that you just saw from Elisa. And the reason why I put this back up is I really want to set the stage for some of the updates that you're going to hear about to the family care plan and the CAPTA process. And in particular, it's around what are the substances most commonly reported being used by pregnant people and postpartum people. So you'll see here, alcohol and cannabis are by far and away the most commonly reported substances used in the perinatal period. Of course, my dog's barking right now. And I also want to point out that the demographics on the left-hand side of the slide around drinking alcohol during pregnancy and cannabis use during pregnancy. And just to note that I think that we make some assumptions with the screening and supports, and we know this from PRAM's data, where the people who report the highest rates of screening for substances in pregnancy are younger, Medicaid eligible, and a lower the high school education. But if you look at the drinking alcohol during pregnancy, it's actually over 35, private insured, higher than high school education, reporting the higher rates of use. So I just want to always like put a little pin that we need to be screening universally, and we need to be screening for all the substances, not just focusing, on the illicit or the MOUD and opioids. Next slide, please. We talked about this. This is some of the data on the left of the maternal mortality panel showing national timing of maternal deaths and Vermont's timing of maternal death. And in Vermont, we by far and away have the highest levels of death in that period post OB care. That's one of the reasons why I loved the Central Vermont team's primary care connection there, because we are seeing that people are passing away in that period after they leave OB care, and we need to do a really good job in the prenatal period of connecting them to supports that are going to be there in that full year after birth. And I think we need to shift our lenses again from thinking of this as a MOUD, and or opioid illicit use population, and really recognizing like there are multiple substances happening here, and we can't be associating as strongly our perinatal substance use with just the opioid population, because we see polysubstance use across the board. And we also don't really know when they're coming across our desks in the prenatal period, what's going to happen in that full year postpartum. Next slide, please. Oh, I'm sorry, before we dive in, I want to just say a couple of things before I thought I had one more slide. Just when we're expanding the indications for the family care plan, one of the things we took into account was the idea that this is not a punitive approach, and we're seeing substances, like I said, polysubstance use and multiple substances happening. And so we really want to focus on what do these families deserve? The family care plan is a supportive process for a family to get supports in place in the prenatal period that will last the whole postpartum period. So it's really about what do they deserve as supports, as opposed to like stigmatizing and identifying those people with substance use. So I just really we'll repeat that multiple times in this, but I just really want people to hold that we're expanding the indications from the family care plan development with a purpose that's based on the data that we're seeing, and that's based on the assumption that families deserve these supports across the board. All right, thanks.
All right. So I'm going to take over here for a little bit, and any of you who have seen me over the last 5 years knows that I've been doing this since 2019, and we've been through a lot of iterations, and we certainly could talk more in depth about those at another time, but it's just really important that we're all grounded in what the federal legislation does and does not say. And that's really important, again, as we get back to what Lindsay mentioned around people's fear around substance use and reporting and what the actual risk is. So this is a very old piece of federal legislation. It was initially enacted in 1974, and this is a huge body of legal stuff that I just read through again for like the 5th time. And I just want to remind people that this is not just looking at substance use. This is looking at all areas of child abuse prevention and treatment, and it brings funding to the states to help support prevention measures. So this is an important funding that the state needs, and in order to receive that funding, we need to be in compliance with those recommendations and requirements. So in 2003, the amendment was that governors had to assure that there were policy and procedures in place to identify and address needs of infants born with and identified as being affected by an illegal substance use or withdrawal symptoms. And that's the first time that a plan of safe care was mentioned. In 2010, they also added substance exposure to include fetal alcohol spectrum disorder. And then in 2016, the CARA Act came in and amended CAPTA that clarified the population that requires a plan of safe care to those infants born with and identified as being affected by illegal substance exposure withdrawal symptoms from prenatal drug exposure or fetal alcohol spectrum disorder. So again, a lot of federal language here, but I'm going to break it down a little bit better in the next slide. Next slide. Here we go. So just a little more understanding of what CARA was. So this is the Comprehensive Addiction and Recovery Act, and this really helped to bring some actual guidance as to what a plan of safe care was. Previously, it was mentioned, but there was absolutely no guidance in the legislation around how states could enact pathways and protocols for this. So again, the goal here becomes to address immediate safety needs of the infant and the health and substance use disorder treatment of the affected family or caregiver. It had 4 requirements, and again, those of you who have seen me do this before, identifying infants being affected by substance use or fetal alcohol spectrum disorder. Number 2 was notification, and that's underlined it. It should be bold and highlighted as well. Notification to the State Child Protective Services team, the development of a plan of safe care, and the submission of data to the Children's Bureau. And this is aggregate data, not patient-identified data. Next slide. In 2021, shortly after we had gone through a massive revision cycle here in Vermont, we had in 2017 been early adopters through a policy academy to enact a plan of safe care and notification pathway. We did obtain our governor's assurance, and then for several years we went on and continuously did quality improvement to see where we could improve the system. And then from 2019 to 2021, we worked really hard to put out a new system with a website and instructions and frequently asked questions. And we launched that in January of 2021. In December of 2021, CAPTA became reauthorized again, and it came into effect in 2022 and will continue through 2027. And in this way, it actually changed much of the language. It struck out the majority of the original CAPTA CARA language and shifted that language to make it more of a public health response to infants that are affected by substance use disorder. So I'm going to quote here, the new purpose was to ensure the safety, permanency, and well-being of infants affected by substance use by supporting states in providing a public health response to the impact of substance use on infants, mothers, and families. The language was then updated again to infants born with and identified as being affected by substance use disorder, including alcohol use disorder. And this is very important because there was a lot of hiccuping around using fetal alcohol spectrum disorders, being that many infants in that first year of life, there was a hesitancy to diagnose fetal alcohol spectrum disorder, as previously it really relied on both their overall presentation at birth, but also the development of motor delays or other developmental milestones being delayed. So this change really highlights that alcohol use disorder is a big problem in pregnancy, as we've just talked about, and that you don't have to have a diagnosis of fetal alcohol spectrum disorder to help support these families. Next slide. So in CAPTA 2021, so the current CAPTA legislative language, the plan of safe care language was replaced. And this is really important as well. It now becomes family care plan, and you'll hear us all continuing to call it the family care plan. On our old documentation from 2021, everything continues to say plan of safe care. Now, as you can imagine, that's a very loaded topic to call something a plan of safe care and to give it to families. It just feels very discriminatory and accusatory. And no matter how you put it forth, it seems like people are being selected for possibly not being safe in providing parenting supports to their children. So family care plan is the new term. And this is again trying to move to a family assessment approach. So moving back to help develop that family care plan in a way that supports the family, and addressing this through coordinated services, not just the infant's needs, but the health, well-being, and substance use disorder treatment needs of the affected parent or caregiver. This also asked that there be systems developed to determine if referrals to appropriate services for the infant and the affected parent and caregiver are occurring. So this is another layer that I think holds people and states accountable, in that the prior legislation let each state develop their own system. This is now saying we need to see if those referrals are happening and people are getting the services they need and deserve. Next slide. So the other language I really wanted everyone to take with them, again, to help us understand what this law does and does not do. It very specifically says that those notifications that are required as part of CAPTA are distinct and separate from the child abuse and neglect reporting. We've been doing this in Vermont since 2017, but many states chose a different pathway, requiring all mandated reporters to report through child abuse hotlines parents that were using substances during pregnancy. And that's a very different pathway than notification and trying to support families with appropriate resources. So these notifications are designed to promote public health response. And again, reminder, including alcohol use disorder, and then not for the purpose of initiating an investigation of child abuse or neglect. That is a very separate pathway that should be done if there are child safety concerns. And again, use of substance alone does not necessarily mean that there are child safety concerns present. Next slide. So I just wanted to put this in here. And so here we are, 2022 to 2025. And I just want to take home, I mean, this is a lot of heavy legislation. We're going to move forward, and Kayla's going to talk to us about how we are making changes. And this is a process, right? So this is like implementing a new statewide process. But just the reminder that we have been a leader here in Vermont, really setting the stage for change in other states, a model of how we can implement a plan of safe care and now family care plan and a notification system outside of the reporting system. And we have decoupled our notifications from the reporting system since the beginning, and have already a mechanism for collecting data from these notifications in a de-identified manner that does not report any information about the parent or child. And so now it's time to re-engage our partners to make sure everybody's using the updated language, to pilot our new workflows, and to further separate DCF from the family care plan. And I'm going to turn it over. Next slide.
I think this is actually the slide that I've thrown in here, and it was just, it was going to be a little bit earlier, I think, just to kind of highlight why, connect to the data of like why we did some of these things. So I think we don't need to go over this because Kayla will go in depth.
Okay, great. So we'll just go to the next slide, please. So just to bring context as to why I'm involved in this work, and I'll talk about this a little bit more later. But Alliance for Innovation on Maternal Health has patient safety bundles, and one of them is the care of the pregnant and postpartum person with substance use disorder. And a big chunk of the bundle is focused on family care plans, patient navigators, building community pathways, and referrals. So I've been really privileged to get to work on this project. So I think it ties a lot of those components together. So next slide, please. So from the beginning, we've been having these conversations for a while now, and we realized we just needed some type of visual to really help highlight the work. And so like Michelle was just saying, really trying to continue to break down the different parts of this legislation and like what's connected and what's not. So we built this table for our conversations because it's always easier to visually see something, I think, than just to talk about it. So we broke this up into the three different sections. And so the family care plan, which was once the plan of safe care, so that new terminology that we're going to continue to keep reinforcing, the goal of it is to facilitate community resources and family support. And there is a mandated, side to this. We're trying to be very transparent when things are part of the legislation. The timing is one of the big components that we're looking at and trying to start this prenatally or at time of disclosure, but not changing the timing of when it's completed, which is that time of infant discharge. We started listing responsible parties, and this is going to be part of our pilot work, is identifying maybe others who may add onto this list. We've taken a look at our inclusion criteria, and again, what you've heard today is making sure that we're encompassing all types of substance exposure. So that criteria is broadening from previous revisions. And then the connection to DCF, because again, we do want to highlight that because we want to make sure we're transparent with our families when we're talking about these things, and that we can hopefully alleviate myths or, some fears of what's been coupled together, in the past or in their minds or in the community. So the family care plan is for the family. Ideally, they will choose to share with their interdisciplinary team during their pregnancy for coordination of care. But this family care plan does not go to DCF unless the family decides that they would like to, because we want to highlight it as a strength and a document that shows all the great things that they've been working on. So if they become involved with DCF at any point in their pregnancy or early postpartum, then they would also be able to choose to share this care plan with DCF, but it's not mandated. And the way that the electronic systems being built, it's going to a secure server that does not directly tie to family child to the family child division at VDH, but not DCF. So many acronyms in this work. And then moving down to the CAPTA notification, again, the goal is to meet that federal reporting, and as Dr. Shepard said, it links back to money to help with this work. So we want to make sure that we're doing the best that we can to meet those qualifications. And the timing's not changing, going to be completed at time of infant discharge by the hospital designee. We're not changing that system. We're hopefully just making it easier. And again, looking at, yes, Lindsay, definitely alphabet soup with all of our all of our acronyms here. And this remains the same with that de-identified data, which Dr. Shepard spoke to, of like being one of our strengths in Vermont, as we have that de-identified. And this again will go to a secure server, but that's different than the family care plan. So there's not any connection between someone's family care plan and their CAPTA other than a checkbox that said, yes, I did both of these things. And then reporting to DCF is its own bucket. And there's different criteria based on DCF policies and practice of when reports should be made by mandated reporters, and that would go through their direct intake line. So again, this is just a visual to show like the different buckets of work and how and if they're connected to each other. All right, we'll go to the next slide, please. So this is a busy slide, but I just want to show a visual of all the work that's been done. And this is just highlighting 2025. We had a 2024 one as well. Purple is CAPTA specific work. The peach is family care plan specific work. And then green highlights both because there obviously is some overlap with the people using these systems. So just to show that this is not a quick revision that we're like, okay, here we go. There's a lot of thought and a lot of feedback going into that. And I'll get into that a little bit more. Next slide, please. I want to give the general caveat that this is very high level, but hopefully give some detail, but also it's not going to answer all of your questions. So we, part of our process is having feedback sessions. So we're going to talk about those a little bit at the end, but just know we're not going to get into the nitty gritty of how it works at each system, but just to give some insight as to how we've gone about this revision process. So one of the biggest process changes is updating both our CAPTA and our family care plan to be virtual or be electronic. So that we're utilizing Microsoft Forms and secure HIPAA compliant servers. We're making sure things are mobile friendly, so not only on tablet or computer, but also via cell phone. We're trying to limit the steps in the process so there's not multiple points where things could break down. And this will also help us streamline the data collection, which will be really nice for both um, family services division to be able to report out the mandated reporting things, but also for our quality improvement to make sure we are meeting the needs of our Vermonters. And for the family care plan specifically, this virtual platform will allow us to re-access for updates and be able to edit who receives those updates. So we're really putting as much ownership and autonomy in the hands of the pregnant person in order to have this be a process that works for them and their family. Next slide, please. So a little bit more, this is just a snippet of what the form looks like in its draft form right now. But end users, those who will be submitting the CAPTCHA specifically, will have a URL or QR code to be able to submit, and we'll also have a updated website with links there as well. A couple of things that we just wanted to highlight that is different is we're going to address residency because there's some inconsistencies in our practice of whether hospitals across the board are doing things the same. So one of the first questions will be, or one of the practice change will be complete this for any baby born in Vermont, regardless of residency. But one of the questions will ask, what is the state of residency? That way we can also separate that de-identified data by state, and then reporting can happen appropriately. It'll also give us, a good highlight. We know from birth certificate data some of the different states of residency, but it'll also help confirm that data pull. We're also made this so you could submit for multiples. So if you have twins or triplets that obviously have the same intrauterine experience, you wouldn't have to submit this form multiple times. And then, like Katie and Dr. Shepard talked about, we're expanding the exposures to make sure we're including alcohol and cannabis so we can get a good picture of that. Next slide, please. This is a snippet of our draft form for the family care plan. It's currently almost done with its first electronic draft for us to be able to start getting some feedback on. But again, this will have a URL or a QR code to be able to initiate. There'll be a question of, are you updating a family care plan? So you don't have to reinvent the wheel every time. There'll be a level of security with a PIN or some type of questions to be able to input the information to the right family care plan. A big change is universally doing this in the prenatal setting. We do have some regions who already have this as part of their practice, which is wonderful, but we understand through the data and the MMRP that the getting services and report earlier on is only going to benefit our families. So we really want to make that universal. And then again, who will it be shared with will be driven by the pregnant person, the pregnant patient. So we really want to highlight that. And I can't remember if I talk about it later. We are trying to make this as easy for the pregnant person as well as the people surrounding them, the healthcare providers who are helping assist with this. So if they decide they'd like to share this with their OB provider, which would be, ideal, we will have a database in there. So if they say, I see this provider at this clinic, then we would have a database built into the system to be like, oh, here's the email address or the fax number associated with this office. So you, as the person helping fill this out, aren't having to Google or figure out how to get this sent to them securely. So that's our work in the next couple of months, is building that database. So hopefully we can ease the lift there. Okay, next slide, please. So in general, I just want to share what our piloting approach has been. So first, our small work group went through, as part of the IDTA, went through an updated draft. Like, what do we see as being the next version of this in order to provide that full prenatal through intrapartum through postpartum spectrum for our patients. Then we worked with an IT colleague at VDH who has been wonderful in creating this into a secure Microsoft form. So shout out to Victoria. And And then we started bringing some partners who are interested in this work and we knew were already doing this work for initial feedback. Helped us trial the form, make sure like the click buttons are working, the branching's working, just to get some initial feedback. And through these feedback sessions, we also identified some pilot sites. So we provided some more in-depth education, working with those teams to pilot. And then following a pilot, our plan is to have debrief or feedback sessions with the end users, what worked. We're going to pull the data with our VDH IT team to ensure that it's pulling the data that is needed to meet the federal requirements. And then we're also creating educational materials for patients, families, and healthcare professionals, and having that be part of the pilot so we can get feedback. Is it clear? Is it patient friendly? All of those things. So we're trying at every step of the revision, make sure we're getting feedback. So I'll go to the next slide, please. So to share, we are actively piloting the CAPTA portion of this. UVMMC and Rutland Regional are our 2 pilot sites currently to trial this electronic form. Both sites utilize a social work case management team to complete the CAPTA. So they're already familiar with the process. It was changing the way in which they completed it. We plan on piloting through June, although we are looking at numbers and make sure we're capturing enough to really get some a good sense of whether there's any edits to be made. And then we will hopefully have a smoother system after a pilot and be able to reach out to each region and make sure we can walk them through the updates and be able to go live with this across the state. And then, so this is an example of the piloting structure. And that's what we plan to do with the family care plan. So we started with CAPTA because it was a little bit more streamlined. That's the same people who already knew about CAPTA, whereas family care plan is going to take us a little bit longer because there's a lot more players involved. And we want to make sure that everyone's comfortable with their role, understanding their role, it works for their process as much as humanly possible when we all have very different systems. So that one's going to take a little bit more time, but we've been doing this in the same structure, but a little offset because we could get CAPTA up and going a little bit faster. So we're in further down the line of the pilot with the CAPTA, but we will just recycle and repeat for the family care plan. So next slide. I'm not going to get into the nitty gritty of this because we do plan in the fall when we're, through our pilots, be able to provide an implementation webinar and get into the nitty gritty. But I just wanted people to be aware that we are really thinking through all the different aspects. So we have flow sheets for every type of office that we think would come in contact with the family care plan and what we've drafted as what we think the process could be, knowing we're going to need edits. We don't think that we have all the answers. We don't think that we've thought of all the questions, but we wanted to come at least with a good start. So we're not starting from scratch in every region, but hopefully have an ideal starting spot. And then we can work region to region to figure out what works best with your settings. So for an example, like an OB office, we're fortunate that all of our OB offices that we received reports back from are screening at some point for substance use disorder. So we're encouraging that first appointment or when they first come in for care. And then we've got a couple different pathways. We're really trying to connect those community ties. So we're working, there's another kind of QI project that dovetails off of this with Help Me Grow and utilizing them as a resource. Our ideal plan is to get our home health colleagues involved early on prenatally and to be the ones to help initiate the family care plan, because that will also help provide those wraparound services through the first year postpartum. I know Katie wants to chime in on that, so I'll pause.
Yeah, I was just, I warned Kayla I was going to chime in here. Just thinking, we were really intentional about selecting our partnership here, knowing that it may change over time and it's not set in stone. But one of the reasons why we chose the home visiting nursing is we know that it's across the entire state in every region. So it's a resource we can recommend and develop a systematic approach to involving them. But also knowing that oftentimes infants exposed to substances can be born with medical issues and or feeding issues, and that we know that our nursing staff is well trained in addressing those issues and partnering with that. So we really were intentional, and also the data we've reviewed multiple times today really shows that yes, opioids are an issue. So there are people that might be more, MOUD prescribers and things like that might be more familiar with the opioid issue, but there's a lot of other substances on board. So we really need to make sure that we have a resource that can sort of support a family in that prenatal through full year postpartum with some of the nursing and clinical care, but also a range of substances. So just to kind of set the stages, we are partnering with the home of visiting nurses and knowing that that may change over time as we develop the resources going forward.
Great. And we know too that not all families will consent to working with home health. So we need to have backup plans. So we know that we are going to continue to encourage that because we know the benefits from that, but we know it's not going to be reality. And it might take us a little while to kind of change the scripting and change the feelings of that and kind of debunk some myths along the way. So this is just one flow chart of one option at an OB office. And again, very high level, very just get us started in these conversations. And then next slide. We just tried to capture all the different partners who would come in contact with a family care plan. So I'm not going to get into these, but just to show that we're trying to include everyone. So home health has their own. And then next slide. We have a different pathway for OB offices when there's declining of the home health referral. Next slide. We don't want to forget our colleagues in the MOUD space, because through our initial conversations, we found 2 sites already who would be interested in helping initiate or continue the work of the family care plan. So we kind of have 2 pathways here. Some of the hubs may be interested in this because they have built-in pathways to work with pregnant patients and they have a built-in system, where others may just be the recipients of it. And we want to make sure that there's knowledge as well of like why they're receiving this, because the pregnant person decided I would like to share this with my MOUD provider, and it's an awareness of what they have for supports. And then next slide. We're building in kind of a recheck or update your family care plan kind of trigger in pregnancy, because we also want to make sure we include our inpatient teams, because it's really important to have the outpatient talk to the inpatient side. We know there's silos, so we're hoping this helps bridge some of that, and it helps, like Ariel spoke to you, sometimes you just say your story or you say your services many, many times throughout pregnancy. So that is one of our goals too, is with having this electronic and being able to be shared by the patient who with their team who they view should know this information. It hopefully will help cut down on needing to repeat themselves, and for help healthcare providers have it in front of them when they're in a fast-paced environment and need to kind of have something clear in front of them. And then next slide, please. And then, of course, cannot forget our pediatric medical homes, because that's where our families are landing after delivery, and who gets to see them the most, especially when obstetric care has been completed. And I want to shout out Jennifer, who commented about the PCP. We've also built in a question about, do you have a PCP on your family care plan, to hopefully generate those conversations and get those first appointments months after obstetric care, or have a warm handoff. Like, we're trying to build in those steps to help along the way. But making sure our pediatric providers are aware of family care plans, that they'll be receiving them, what is their role in it. So we really want to dive into that, because we think that potentially has been a gap in the past that we can hopefully help with this new iteration. And I'll go to the next slide, please. So for our family care plan pilot, which I spoke to, it's going to be a little bit of a bigger beast. We have in our initial conversations kind of come to the thought of piloting 3 different tracks. One would be that home health referral from the OB office, and home health owns the initiation and the feedback loop associated with that. A second one would be an OB office already has personnel who initiates these and would like to continue that. So we'll pilot that and work through the process. And then we've also, like I spoke to, have had 2 different hubs who are interested in assisting with this work as well. So we plan on piloting 3 different ways because we know not one size fits all. And we want to be able to ensure that these pathways can work and what are the steps we need to do to complete that, and then be able to come back to our regions and say, okay, these are the pathways we've established, these are how they work, what's going to work in your region. Again, all of our systems are different, so we know one size will not fit all, but we want to come already with some mapped out ideas. So again, we're not starting from scratch, and that ideally we have a limited number of systems that are working. And this, as Katie also spoke to, might expand over time. There's nothing magical about the family care plan that not anyone could help a person fill it out, or the patient couldn't do it independently. But we don't want to jump to that. We want to make sure we are having those conversations where, doing referrals in the moment if possible. Like when people are saying they're ready for things, we want to be able to, act upon it. So, but we want to start a little bit small to make sure the systems themselves work because it's such a big change, and then be able to expand outward from there in future iterations if need be. Next slide, please. So just for awareness too, like I mentioned, part of our pilot is also revamping the patient-facing and the provider-facing materials because there was such a big shift. We needed to update things, so we're working on these as we go, so we can also get feedback. So these are just a snapshot of a couple of the handouts, which has already gone through a couple drafts. We're working on a video, and we're working on our website portrayal of all of these things. Next slide, please. Same thing for the healthcare professional handouts, a little bit more clinical based, like algorithms, like we're all used to, just to help determine who needs what based on the federal legislation, and trying to really spell out the mandated reporting guidance as well. Because we know, even though we're trying to separate them, that they all intertwine at some point potentially, or questions at least intertwine. So we want to be able to address those in these materials. Next slide, please. So this is just a list. We plan on providing educational materials in a variety of ways because we know there's different ways that clinics and inpatient units all receive information. So we're going to have the same information in a couple different ways. That way, however it's easiest for you and your staff to receive the information, you have options. So this is currently being built right now, and then we'll be open for some feedback. All right, last slide, please. So what are next steps? That was a lot of information we crammed at you in a very short period of time. So really for awareness, like I said, we're going to be trying to build that database within the family care system, the platform itself. So we will be reaching out to, I specifically put pediatric homes, but it'll be much larger than that. OB offices, hubs, lots of different entities to identify how you would like to receive a family care plan if a patient of yours said, yes, please share it with my provider. This could be fax or email, but we need that information to be able to build our database. We do recommend that if it's an email, it's not tied to one individual person, but it's more of a general inbox, or it goes to more than one person just in case someone leaves or goes out on leave. We don't want family care plans like piling up in an inbox that no one's seeing. We recommend, if you don't already have a workflow for getting the family care plan into a patient's chart or notifying providers that it's there and it exists, that maybe as a team you work through that. And then in general, be aware that changes are coming. We're going to be as global with our communications as possible and be able to disseminate materials to your teams once you receive them. I do want to put a plug in to, if anyone is interested in those open feedback sessions, Please drop your email in the chat and we'll take those down and we'll make sure you're on the list for those feedback sessions because we know we're not going to be able to get into the nitty gritty today, but want to give people as much as possible chances to come to those feedback sessions because we want to make it work. We want to, not double document. We want things to work for people. And then just on the PQC AIM side of things, we're supporting QI with a Help Me Grow and visiting nurse teams with this process, and also supporting implementation with clinical and clinic teams. All right, Michelle and Katie, did I forget anything at the end there?
I don't think so. I'm just looking at the chat here, particularly around the systems of care in the community, whether that's for everybody who's not aware of all the acronyms. There's Children's with Integrated Services, has a couple of different nurse home visiting models. And so we are not dictating which nurse home visiting model people need to be engaged with. We're not dictating any of that. We're working closely with our state partners around the referral pathways and what that looks like. And we're really knowing and trusting our community partners to make those decisions with families about what the family wants to be engaged in and how they're supporting families. So we're not assuming for the communities, nor are we assuming for families what they want to be involved in. I hope that answers those questions. It's not really answering a specific question, it's just sort of addressing that concern because the community systems of care are well connected to each other, and we know that and we trust that.
And I'll add on to that, Katie, that we know that this is not the same in every community. And so we are building that intentionally to make sure that we are putting something together that allows each community or region to adapt as needed. In a separate co-occurring project, we had worked at the medical center to develop a new referral path that would go to Help Me Grow. And with one of those options in our referral path through the UVM Medical Center electronic health record EPIC to be for the prenatal initiation of family care plan. And so, in our region here, it was important for us to make sure there's no wrong door, but there's also one common door to make things easier, because if you're a busy OB practice or inpatient person or primary care provider or anywhere, you need to make a referral. You don't want to have to remember all the different nurse home visiting teams because we see people from all over the state. And so it's very difficult to keep up on it. And people, they change their names and they change their referral pathways. So by starting out with something very broad, like utilizing Help Me Grow and hoping that that pathway can then connect appropriately. Also, sometimes we want Help Me Grow's support as a first level to offer other additional possible referrals and resources to the family. So if they choose to not engage with that home health referral, they are connected hopefully to some other resources just by going through that first screening at Help Me Grow. So it was a pretty intentional way to try to address the fact that we, despite being a small state, have many different regions that work in different ways.
Exactly. And I think acknowledging that there's eligibility differences, which we're not going to get into here because that's a whole bottle of can of worms, but just that we know that people might have a variety of income levels and insurances and blah, 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 all that good stuff that we're like community teams. This is what you do best, work together and figure out supports for a family. The pieces that we really wanted to highlight here is the intentionality of connecting people prenatally with those postpartum supports in their own communities, because I think as providers, and I'm including myself in this, we tend to think, oh, I don't want to, our best intentions are not to stigmatize a family by, singling them out for supports if they have substance use. But the reality is we need to be offering these supports because as providers, we know that is a best practice. That's a care plan for a family to provide them with supports, and we need to offer them. And in my personal experience of working with families, not all the time, but generally speaking, they actually really appreciate extra support. Surprise, surprise. It turns out that they like the help and support. So I think that as long as we're focusing on our respectful care and respectful screening and respectful offering of supports, we can't assume families are going to feel stigmatized if we offer supports. We need to assume that just like all the other families we support, you know, every new family can use some help. So I think just kind of reframing that, like the family care plan isn't stigmatizing and selecting certain families for, you know, a punitive approach. It's recognizing they may need an elevated level of supports and wanting to offer that to families that deserve it. So I kind of just like to remember that.
Katie, and I realized something I forgot to say too, is the way we built this family care plan too, is it could be utilized for any pregnant person. And we know ideally, like we would be able to provide this level of care planning for everyone if we had the bandwidth, but we know that we may not in every region. So we do want people to know that this can be utilized for any high-risk patient, for any patient. We're building it that way. Because we do believe in universal supports and then also making sure those who need extra supports get it. But there's nothing special about the physical form that anyone couldn't use for any type of for any pregnant person. So maybe ideally down the road it will be broader used in a broader population. But are there any questions that people want to come off mute for?
We're just acknowledging some of the lovely comments as well. Molly saying improving care for the most disadvantaged will improve care for everyone, and I think that's really true. And yeah, some lovely comments. And Michelle, I like your comment about the PRAMS data as well. That's great context.
And the great thing about moving this electronically is we'll also have better data to show what referral sources patients are taking on and taking on prenatally versus postpartum. Like we'll be able to have a little bit of a timestamp with which services are being utilized. So that for can also help shift money around or resources around or awareness. So we're really excited for the potential of just knowing a little bit more with this being in a different format and being able to collect so much de-identified data. Just want to put that plug in there.
And regional de-identified data, so you'll be able to see, because the PRAMS data isn't regional, which is, you know, one of its issues. So we'll be able to say like, oh, North, you know, really kind of identify that around. Yeah, and there's a couple comments I see Carol joining in here around the mental health piece and and substance use counselors. And, you know, the other piece we're working really hard in the state to pull in our peer coaching partners and, you know, lots of different services, turning point centers in every single region, really supporting them to understand that the perinatal period is a little bit different and help support their education there too, which we have some talk about later. So mental health and substance use are really closely intertwined, as we all know. So really being mindful of that as well.
And also, just because we didn't show all of the fields because it would be a bit overwhelming, there very much is fields on the family care plan to have the family identify their other supports, including mental health and substance use counselors, and helping engage them and include them in the family care planning process is just really critical. And again, just breaking down those barriers and silos between all of us as we continue to support our families. All right, well, this has been a wonderful first half, and I am going to set us off to a much needed break. We're going to reconvene right at 10:05 for the second half of our morning, but please feel free to continue to enter questions into the chat and we will address those in the next half.